Welcome to Webisode 11 on pain management for patients on methadone or buprenorphine. I'm Eric Morse, an addiction psychiatrist. I've got over 18 years of experience working in opioid treatment programs. The treatment of pain in patients maintained on either methadone or buprenorphine may be one of the most misunderstood medical situations that our patients face. Many of our colleagues are afraid to treat acute pain in our patients, mistakenly believing that once daily methadone or buprenorphine provides all the pain relief that a patient needs. Providers at OTPs can and should intervene to provide education and guidance to our colleagues in primary and specialty care. Once daily maintenance medication usually prevents withdrawal for at least 24 hours, but the analgesic effect is much shorter. We know that chronic administration of methadone and buprenorphine does little for acute pain. In fact, due to our patients' tolerance to opioids, they often need more short-acting pain medication for relief compared to opioid-naive patients. Best practice guidelines tell us that methadone-maintained patients need to be treated with short-acting opioids for acute pain events, just like other patients. Of course, mixed agonist-antagonist opioids like Talwin, Stadol, and Nubane should be avoided because they will precipitate acute withdrawal. Short-acting opioids like oxycodone, hydrocodone are often used with good results. We prefer not to change the dose of methadone, but continue the usual maintenance dose throughout the acute pain episode. Buprenorphine, because its high affinity for the mu-opioid receptor, is a little trickier during acute pain events. In the past, experts felt buprenorphine would have to be stopped in order to get any analgesic effect from short-acting full opioids for pain. As time has gone by, we learned that this isn't the case for most patients. The current best practices are either to keep the patient on their usual dose of buprenorphine and add short-acting opioids, just like we do with methadone patients, or decrease the buprenorphine dose to 4 to 8 milligrams per day and add appropriate short-acting opioids. We need to educate our colleagues that it is unethical not to treat acute pain in our patients with opioid use disorder. For acute medical conditions like kidney stones, broken bones, postoperative pain, opioids are not only appropriate, but recommended. If the patient is sent home from the hospital or emergency department with opioid pain pills, we can help them identify a safe family or friend who can be trusted to hold the pill bottle and dole them out to them as directed on the label, or to help give our patients extra support and accountability. This is to avoid overuse of the medication. Chronic pain is more difficult to treat. Because our patients have opioid use disorder, we prefer they not be exposed to continuous opioid prescribing. Besides, many studies show limited benefit for opioids for chronic more than 3 months of pain relief. We prefer our patients get chronic pain treated at a more holistic way, including non-medication treatments such as physical therapy, acupuncture, massage, guided imagery, or CBT. However, it's difficult to find pain clinics that offer these more extensive treatments. There are also non-opioid medications that can help some patients, including injections of corticosteroids, topical analgesics, NSAIDs, duloxetine, and other medications. For OTP patients needing end-of-life care for cancers or other terminal illnesses, heavy continuous opioid therapy may be indicated with oxycodone, fentanyl, or hydromorphone. Again, collaboration with hospice and other providers is essential in coordinating care in a manner that meets patients' needs while reducing the risk of opioids as much as is reasonable. If you have further questions, please feel free to contact your state opioid treatment authority. Thanks again for watching, and keep up the good work.